going to get started. We're going to be talking about cell reg this morning, the concept. We're going to be focusing on brain tumor, laryngeal cancer, and skin cancer, okay? All right. Okay, can everybody see that? All right. All right. So, let me see if I can get my thing to work. Okay. All right. So, um, in the brain, there's a hypothesis known as Monroe-Kelly doctrine, and this is just a little FYI that you might hear when you're nursing, especially if you are working in a trauma unit or ICU. And basically, what the Monroe-Kelly doctrine states is that the sum of the volume of the brain, which is the tissue itself, cerebral spinal fluid, and the cerebral blood continuously flow, okay? And they're continuously shifting. So when one is injured, the other two will either decrease, either one or both will decrease in mass, okay? And so there's a shift. And that's basically all the Monroe-Kelly doctrine states. But I just wanted to put that out because you might hear that term. All right, this is a picture, and it's just a picture of types of brain tumors that you may have heard of: gliomas, meningiomas, pituitary tumors, acoustic neuromas, also known as schwannomas, medulloblastomas, neurorectodermal and germ cell, and craniopharyngiomas. Okay, some are malignant and some aren't. I'm going to be focusing on the meningiomas today. Okay, there's 5 common places that they occur. And here's a picture of where they can occur. Okay, all right. So meningiomas are the most common brain benign intracranial tumor, and they can grow in different areas of the brain. Okay, the symptom, of course, depends on the size and the location. And usually with this type of brain tumor, they're not found, they don't just pop up. Usually they're diagnosed when you go in for something else. Like if you're having headaches and you go to the doctor for a headache, or you have an earache or ear problems, or maybe even vision problems, and you go to the doctor and they'll pick it up. Okay. They can quietly grow for years. There's a lot of people walking around with meningiomas and they don't even know it. Okay. And they can get surprisingly large before they start showing us symptoms. Okay. Um, the question is, to do surgery or not? Well, it depends on, the location and the side effects that the patient's having. And of course, if it is going to be removed, it's going to be removed by doing a craniotomy. Okay. There's other types of tumors, acoustic neuromas and pituitary tumors. When you have a pituitary tumor, if it is in the pituitary gland, it can affect other areas of the brain. Okay. When somebody has a brain tumor, they may exhibit headaches, memory loss, seizures, nausea and vomiting, vision changes, poor decisions, weakness of the limbs, loss of sensation, smell, taste, vision, hearing, and balance. Also, personality changes, and also language changes. It's been reported that some patients that have had tumors have started speaking another language. But the meningiomas are basically benign. The glioblastomas are the most common malignant brain tumor, okay, and that's a rapid onset of symptoms. And usually the prognosis for glioblastomas is not good, okay? Okay, pituitary gland. Of course, you know that the pituitary gland affects different areas of the body, okay? And depending on where, how the pituitary gland is affected, it can, the patient may exhibit different effects depending on what type of organ that the pituitary is affecting through the pituitary gland. You see that's transsphenoidal hyphosectomy. Has anybody had a patient with that? No? Okay. Um, this is Miss Hopkins and I were talking about this yesterday. She had a patient in ICU with one. This is when a patient has a pituitary tumor, and they'll usually make a slit right up underneath the gums. Okay, well, like right here. Okay, and they'll go in through the gums and up to get to the pituitary gland. Okay, so with this patient, they're not gonna have a craniotomy, where they're gonna have an incision on the skull. They're gonna have an incision up through the gums and up here. Okay, so my question to you is, all right, so they're gonna have packing after this is over with. Okay, so my question to you is, um, how are they going to get oxygen? How can you provide these people with oxygen if they have nasal packing? Any ideas?
Like, oh, I don't see.
Oral,
Like
Globite,
Huh?
oral airway,
They're going to give them oxygen via the mouth, orally, okay? Because they have to have supplemental oxygen. They'll give it through the mouth, okay? What would you expect that the doctor and the nurses would teach these patients not to do? Think about where this surgery is.
not to sneeze or do anything.
Yes. Who said that?
Ashley Green.
Thank you, Ashley. Yes. If you could turn on your camera so I could see you, I'd appreciate it. Yes. Not to sneeze, blow your nose, anything like that to cause pressure. What, as a nurse, are you going to be assessing for after surgery? You're the nurse, right?
Might want to see if there's any drainage or fluid.
What type of drainage?
Clear.
Yes, because what does clear drainage indicate? Possibly.
CSF.
Yes, yes. Even if they have a little bloody drainage, okay, if it looks sort of clear in between, you may want to test it for glucose, right, to make sure. And if there's a ring, then that's CSF fluid, right? Okay. So good. Sometimes they can have drainage through the ears if they haven't surgery. So any kind of drainage that's not normal, okay, you want to be looking for. Okay, so this is part of your monitoring. When I'm doing clinical, I ask my students, okay, what are you monitoring your patient for today? Okay, so these are the things that you would be responsible for monitoring. Okay, good. Okay. So, like I said, these type of tumors can arise anywhere within the brain. Your primary tumors that originate within the central nervous system are rarely metastasize. Your secondary brain tumors result from metastasis from other areas. So, if you have a patient that had, and you hear them say, "Oh, the patient has lung cancer with mets to the brain," that's a secondary brain tumor. Okay. They expand and they can invade and infiltrate, compress, and displace the brain tissue. That's what Monroe Kelly doctrine was talking about. Everything's going to shift, okay? Of course, and this will lead to cerebral edema and tissue inflammation, increased ICP, neurological defects, hypothalamus, and pituitary dysfunction, okay? Okay. So, of course, the interventions are going to depend on the type of the tumor and the size and where it's located. okay? Most brain tumors will, people with brain tumors will not only get chemotherapy, but they'll receive radiation as well as surgery, okay? Stereotactic radiosurgery is when they go in and they use accelerated X-rays to get to the particular area, or they may implant an isotope seed into the tumor to help shrink it. Okay. Of course, the goal is to decrease the tumor size. Okay, and to improve the quality of life. And of course, the goal with surgery is maximum resection to get as much out as possible. All right, chemotherapy. All right, these patients are going to have chemotherapy, maybe before and after the surgery, and they'll probably have chemotherapy to shrink, um, to help shrink the tumor, and then they'll do radiation therapy behind that. Okay, um, and of course, the most there are some patients that have severe comorbidities that cannot have surgery. And we had a patient a couple of semesters ago. He was elderly and he had a tumor, and they couldn't operate because of his. He was too sick. So what they decided to do was give radiation and chemotherapy to help ease the symptoms, and so they use it as palliative care. All right. Radiation is typically done 5 times a week for up to 6 weeks, sometimes longer. Okay. Um, Temolizumab chemotherapy. This is usually given is the most common type of chemotherapy that's done. It's given during and after radiation. But the good thing about this drug is that it doesn't have a negative effect on the quality of life. They're really, as science advances, more and more chemotherapy drugs are not as harsh on the system. And with these patients, of course, you can probably see they're going to have anti-epileptics, right? Because they're at risk for seizures. And they're also going to be on steroids. Now, let me ask you something. All right, what type of steroid do you think they're going to put them on? Does anybody watch? Anybody knows about? Everybody knows about COVID. Okay, if you've been watching the news, what type of steroid do they say has been effective?
It starts with a B.
Yes, dexamethasone. Okay, they'll probably be using that. Okay, that's in your critical care book. All right. All right. So those are some drugs that you may see used along with the chemotherapy and radiation. Okay. Chemotherapy.
Outside, did you find her caller?
Huh? Did somebody say something? Okay. Chemotherapy will help shrink the tumor before the radiation. Okay. It's like I said before, it's effective before and after radiation, and it'll destroy the remaining cells after surgery. You'll hear some people say, well, I have a good immune system, so that's going to help, help kill the chemo cells. I mean, the cancer cells. Your immune system does not kill cancer cells. Only chemotherapy and radiation can kill that. Okay. All right. Craniotomy. Now, this, as a nurse, okay, if you're taking care of one of these patients, you'll, like anything else, you want to do a baseline exam, right? So you'll probably be doing a baseline exam, vital signs, full neuro exam, psychosocial exam to see where they are. Isotonic IV fluids may be started on this patient prior to surgery. They may give them blood pressure medication prior to surgery, corticosteroids, and even anticonvulsants pre and post. They may even require antibiotics and, of course, DVT prophylaxis and imaging if needed. The imaging is usually either CT or an MRI. Okay? All right. Post-op. Post-op care, of course, you're going to be monitoring the patient to detect changes in their status, right? And you also, the reason why you're going to be monitoring these patients is changes in status and also to, like any other patient, you want to help to prevent or minimize any complications, especially increased in intracranial pressure, like Miss Wig's lecture. They're having surgery, so these people have brain tumors. They have increased intracranial pressure. After the surgery, they may have some post-op swelling, so you're going to need to monitor that ICP. Okay. Um, so, just like Ms. Wiggins talked about in her lecture, you want to keep them supine with the head of the bed 30 degrees. Okay. You're going to avoid hypotension or hypertension. Okay. You're going to monitor their electrolytes, strict diagnose with weights. You want to monitor their hourly neurochecks, and you're going to monitor their pain control. Because what happens, someone tell me, what happens when the patients are in pain?
ICP goes up.
Absolutely. Okay. And so with the pain medication, they're probably gonna want to give them something that's short acting, usually something like morphine. Okay, and they may even give them IV Tylenol. Okay, are you going to give these patients NSAIDs?
Mm-mm. No.
No.
No, no NSAIDs. Okay, all right. Hypertension can cause hemorrhage to the surgical site and cause cerebral edema and increase the ICP. And low blood pressure can cause hypoperfusion and ischemia. Okay, so you need to watch for hypovolemic shock. Now it says incentive spirometer Q2 hours. Okay, now yes, they go, well, they've got incentive spirometers can cause increase ICP, but you're not going to have them blow hard. Okay, you're going to have them just gently take deep breaths, but they need that incentive spirometer. Why? Why do you need to make sure they're doing that?
Oxygen.
Yes, okay. Just like your cabbage patients, okay, and your pneumonia patients, you need to, because pneumonia will set in very quickly, okay? Ice packs for the edema. So when they get out, they'll have a bandage on their head. Usually after 24 hours, they take the bandage off and have the incision open to air, okay? So like anything else, if they have edema or swelling and it's painful, okay, you want to put ice packs or cool compresses on that area. There's nothing better than ice for something that's hurting, okay? You're going to avoid hyper and hypoglycemia. Okay, so this is going to be strict glucose control. One of my students asked me yesterday, are there any ranges with the strict glucose control? I'm sure just like a sliding scale, the doctors will have parameters for you, okay, but just know that, you have to really monitor that glucose, because even though they're not diabetics, they're going to be on steroids and they're probably going to have some increase in their glucose levels, okay? And of course, you want to monitor any drainage from the ears. Like I said, with the transsphenoidal, you want to make sure that they're not blowing their nose or nothing over their nose or sneezing or anything like this. If they need to sneeze, what would you teach them? Any ideas? Sneeze with your mouth open. Try sneezing with your mouth open. It'll stop it. Okay. All right. Let's see. And of course, if somebody has a drain anywhere, okay, like if they have a brain abscess, okay, because yes, they can get a brain abscess from the surgery. If they have a brain abscess, they're going to put a drain in the head. Okay, never put any type of drain to gravity. Okay, never put any type of brain to suction, only to gravity, because you'll be sucking everything out of their brain. Okay, so you want to avoid sedation if possible. Why do you want to avoid sedation?
You can't do the
won't be able to-
neuro checks.
Exactly. So they're going to give them short-acting pain agents to control the pain. Okay, they can be reversed easily. Okay, They may even, besides a brain abscess, okay, they may even have meningitis. They may, so what happens? What are the signs and symptoms of meningitis?
Headache.
Nuchal rigidity.
Nuchal rigidity. So they may be sitting there going, my neck is stiff, and of course, yeah, their neck may be stiff from laying there, but yeah, it could be nuchal rigidity. It could be meningitis. What are other signs and symptoms of meningitis? Fever, right? Headache. Okay, photophobia. Another sign. This is why you need to do head to toe assessment. They may have a petechiae rash on their torso or lower extremities. Okay, and that may be a sign of meningitis. Okay, if they have a brain abscess, they'll probably be on antibiotic therapy. Okay, let me see what my next slide is. Okay, so position's important, like I said. So they're going to be 30 degrees. Okay. They will probably have a peg tube at first, okay, depending on what's going on with them, okay. Once they start to eat, some of these people may have a peg tube, okay, but once they start to eat, you have to assess that gag reflex before you give them anything by mouth, okay. Like I said, you have to assess that blood pressure, maintain that blood pressure, assess GI. What do I mean by that? Why do you need to assess the GI?
Make sure that
Like
it
bowel
has
sounds.
active bowel
Bowel
sounds.
sounds.
Yes, especially after surgery. Okay. Think about this too. Okay. They're on all these medications, steroids, antibiotics, maybe, anti-epileptic medications, blood pressure medications. They're at risk for GI ulcers. Okay. So you want to make sure they have either a PPI or an H2 blocker on board, right? Okay, and you want to assess those bowel sounds, right? And not just say, active bowel sounds times 4 quadrants. Nurses are usually the first ones to pick up on small bowel obstructions, okay? All right, let's see, I think I said all of that. Okay. At the bottom it says isotonic or hypertonic only. Okay, don't want to give these people hypotonic solutions. Why don't you want to give somebody a hypotonic solution?
Cerebral
That's going
edema.
to increase cerebral edema.
Absolutely, absolutely. Hypotonic solutions will increase the total brain water and, of course, increase the ICP. Now, when I say hypertonic solution, I'm not talking 3%. Okay, I'm talking they might give a lower percentage of hypertonic. Depending on what's going on with the patient. You brain tumor patients, depending on where it's located, go back to Ms. John's lecture. Remember she talked about DI, SIADH? That's usually where you'll see these patients are in ICU from having craniotomy brain surgery, okay? It's usually after some type of trauma, either a tumor or brain injury, okay? So that's, and of course, fluid resuscitation is directed towards not only maintaining normal volume, but also adequate cardiac output and tissue perfusion. Okay? Any questions so far? Okay. All right. Let's talk about chemotherapy. All right. Chemotherapy side effects. Okay. Include bone marrow suppression, nausea and vomiting, mucositis, alopecia, changes in cognitive function. And when I say that, a lot of times it's problems with memory, okay? And they can also experience peripheral neuropathy in the hands and feet mostly, okay? A lot of these symptoms will start 7 days post-infusion. Okay, so what do you need to assess your patients for? Okay. You see that venous access device? Okay. Most patients will have, portacaths, okay, or PICCs or something. But sometimes they'll go in as an outpatient for their chemotherapy, and they'll just put a peripheral line in. Okay, if you're working on an oncology floor and they come in and you put a peripheral line in, you better bet that you are watching that venous, assessing that venous access at least every 30 to 60 minutes during infusion. Why?
To avoid a scoriation of the
Yeah.
chemotox in the skin.
Yeah, very just like promethazine, very caustic to the veins, and that tissue can die. They can end up with a necrotic arm. They can lose their arm. Okay, so it's very important to assess that venous access. Okay. All right, oral mucosa. They're neutropenic, so you need to be assessing, and I say at least every 8 hours, sometimes more often. Okay, depending on what's going on with that patient, because what can happen? What may they develop? They may develop what? Mouth sores.
Ulcers.
Yes, and if you've ever had an ulcer in the mouth, it's extremely painful. Okay, so you can teach them to rinse with the warm water with baking soda and a little warm salt water, and then rinse out. You can teach them to rinse with non-alcoholic mouthwash. Ice chips are always great. And to use a soft toothbrush when they're brushing their teeth. Okay, so these patients are feeling bad. Okay, and so they don't want to do anything. All right, but how often should they be brushing their teeth? Any ideas? Nobody wants to tell me?
Once a shift,
Huh?
once maybe a shift.
No.
After eat, once in the morning, rather.
No.
After every meal.
After each meal.
Every meal and at bedtime. Why? Why? Bacteria. These people are immunocompromised. Okay, so you want to prevent the growth of bacteria. Okay, so not just once a shift or whenever they feel like it. Okay, you have to stress the importance of them doing that. Okay, you want to of course report any temperature of 100.4 or greater. Okay. Radiation therapy. Has anybody taken care of anybody maybe with breast cancer that's had radiation therapy? Has anybody ever seen a radiation site? It's not only the it's a deep radiation, but the skin is burned and it's very painful. So they'll have special creams to apply for that. You might want to wear very loose clothing, okay? But you need to be assessing that skin as well. Okay. Right. All right, so let's talk about plan of care for chemotherapy and radiation. Okay, you're going to be assessing, you're going to do your routine temperatures every 4 hours and PRN if the temp is present, okay? Let's talk about your diagnostic labs, all right? Now, I tell my students all the time, and I'm sure your instructors tell you as well, when you are on the floor taking care of your patients, okay, I always tell my students, okay, so you take care of your patient today, according to what they have, what labs do you expect to see out of whack? Okay, because this is what you're monitoring, okay? So, if somebody's getting chemotherapy, what labs do you think are important to monitor?
White count.
Okay, high or low?
Low. Low.
High. What's your normal rate for WBCs? Your normal range? 5 to 10. Thank you, Nicole. Okay, so it's 15,000. Is that a problem? Yeah, okay. Besides WBCs, what else are you monitoring? So the white count will be elevated. All right. What else will you be monitoring?
Platelets.
Platelets, absolutely. Okay, platelets are going to be what? High or low? Suppressed. Look at that, Nicole. She's just going to town. Thank you, Nicole. Yes, okay. You know, and look, I tell my students the only thing to memorize are lab values and math. Okay, so platelets 150 to 400. They start to drop below that. You need to start watching that, right? All right, because they're more susceptible to active bleeding. What else? What about H and H? RBCs, high or low?
Low.
Low. Okay. All right. Miss Nicole, I got a question for you. How about the calcium? High or low?
Low.
Hi.
Yes. Why? She's
Oh.
thinking.
I'm thinking that
The bone.
I don't know.
broke
I
down.
have a thought, but I don't want to say it because I might.
Okay. Well, I'll add that. High is right. They're going to be hypercalcemic. You know, the CBCs, the H and H, the platelets are going to be low. The W, okay, but the calcium is going to be high because what happens is either the cancer itself or the chemo is going to cause the cells to leak, and the calcium will leak into the bloodstream, and they'll be hypercalcemic. Okay. Was that what you were thinking? Smarty pants. Good job. Okay. All right. So, you know, you're going to be assessing for anemia, thrombocytopenia, neutropenia, right? Okay. Let's talk about nutrition. These people are going to be, have anorexia and cachexia. You know what that is? Okay. What's anorexia?
Loss of.
Loss. Okay, it's when they start losing weight because they're starving themselves. Okay, but in this case, they're not doing it on purpose. So they're going to have weight loss, and they're going to have muscle mass loss. That's the cachexia. That's the loss of muscle mass. Okay, from the effects of the chemo and the radiation, or from the effects of cancer itself. Okay. So what do you think their protein levels and their albumin levels are going to look like? Low, right? Okay. So your normal protein levels are 6 to 8. So it starts to drop. And, you know, if you have an older adult that you're taking care of on the floor, just a normal patient, look at their labs. Most of the time their albumin and protein are low because they're older and they're not taking in as much protein, and their nutrition's not as good as somebody that's in their 40s. Okay. These patients are also going to have an alteration in taste. Okay, a lot of times they will report like a metallic taste. Okay, and they might even have a food aversion. So you have a patient that loves red meat or loves chocolate or loves coffee, and all of a sudden they can't stand to look at it. Okay, so they're not eating. They're not drinking, so hydration's a big thing too, right? All right, so when they're not eating, you need to get them to eat. So what are you going to do?
Small, frequent meals.
Small, frequent meals, absolutely. Also, not only small, frequent meals, but bland foods, okay? You're not going to be giving them anything spicy, okay? They won't take it anyway. Depending on